Good morning. Thanks for coming. So I sent you a number of unknowns for thyroid, and I've added a couple of extra H&Es and some IHCs on some of them. But when it comes to thyroid, mostly like the specific details of the clinical history may or may not be important, right? So I just gave you all this as a thyroid nodule. And then if and when there are clinical scenarios that are relevant, we will certainly talk about them. But in many cases, it's a more morphologic kind of forward diagnosis. We know, however, that the biopsy findings from FNA, right, the Bethesda category, and the molecular findings that may or may not have been present on the molecular testing from the FNA could inform our diagnosis. So when relevant, we'll also talk about those findings. Does anybody have questions or comments or clarifications from anything before we start? From the lectures or from the recordings? Okay. All right. So case one. On low power, I don't even have to magnify. Is this benign or malignant? Malignant, right? Why is it malignant?
Like a nodule with a capsule that has some sort of invasion, perhaps, on several areas.
Yes, excellent, right? So in many cases, thyroid carcinoma will kind of yell at you, right, from low power. I don't have, unfortunately, any of the gross photos here, but right, one of the concepts that we always want to think about when we're grossing thyroid is, do we see any evidence of gross invasion, right? Infiltrative borders, satellite nodules, sclerosis, et cetera. In this case, you may not have seen that because it's small and it's relatively circumscribed, but there's a peripheral collagenous fibrous band, and there are areas of tumor, right, that are overtly on the outside of the band that push into the normal thyroid parenchyma. So based on the morphologic pattern of invasion, not even looking at the nuclei, is this a follicular or a papillary or a medullary or something else? What would be your best guess? Follicular, right? This is the pattern of invasion of follicular thyroid carcinoma. It doesn't have small infiltrative sclerosing nests, right? It generally has large, broad-based kind of tongues of invasion beyond usually a fibrous capsule. And some PTCs certainly can grow in this lobulated infiltrative fashion, but mostly this is the growth pattern of follicular carcinoma, right? So I wanted to start off with something that was like 1000% this is follicular carcinoma. Yes, we always want to evaluate the nuclei, right, to see what the nuclear features are. So now you might ask yourself, okay, these are round. However, are there any features here that might concern you? What's the major feature here that could be described as PTC-like? Clearing, right? Chromatin clearing, right? So chromatin clearing means the center of the nucleus is white and it marginates towards the periphery. Now, are there any other features of PTC? Grooves, significant wrinkles, pseudo-inclusions? Not really, right? So the point I'm trying to make here about the nuclei, right, is that in any tumor and in any given field, you may or may not find some features, right, that are kind of suggestive of a papillary feature. However, in the absence of robust, nuclear features of papillary carcinoma, we kind of can let a lot slide, right? The other feature is that if you scoot around different areas, totally different, right? These are very round, very dark with fine chromatin. So if you have this amount of nuclear heterogeneity, you may not be so concerned for a PTC when you are in the overall morphologic growth pattern of a follicular pattern neoplasm. Okay, does that all make sense? All right, so once you get to a follicular pattern neoplasm that has variable to relatively bland looking nuclei, and you have invasion through the capsule, what is, at minimum, what is your subtype diagnosis of follicular carcinoma? Or I should ask, what are the three main subtypes, or four, theoretically, of follicular carcinoma? What's the lowest? So capsular invasion only is what? Minimally invasive, okay? So minimally invasive FTC has capsular invasion only. What's the next one?
Angioinvasive.
Angioinvasive, right? Has any amount of capsular invasion, 0 to 5,000, right? But also vascular invasion, angioinvasion, because that will predict distant metastases, okay? And then what's the third? Which is a little bit of a not very well-defined entity. Widely invasive, widely invasive. So there's a lot of debate in the literature in terms of what is widely invasive. Extensive, capsular and vascular and intrathyroidal and extra-thyroidal invasion and multiple lobes. There's no specific cutoff, right, for what is widely invasive. So just take that with a grain of salt, but those are the 3 categories. Beyond that, right, once you've decided which one of those 3 categories it is, what is your next step in any malignancy of thyroid to determine if it's
High grade.
high grade? So what defines high grade thyroid cancer?
Mitotic figures, you look for necrosis.
Those are the essentials. Those are the essentials, right? So mitosis and necrosis, and we'll talk about criteria for high grade exactly. However, once you get to cancer, right, then you have to ask yourself if it's high grade. So high grade being true tumor necrosis and or mitoses. I'm not sure I would regard this as necessarily true tumor necrosis. I would like to see ghost cells, right? This kind of looks like stromal, like myxocollagenous degenerative change. So I'm not sure that this is true necrosis, but those are the kind of features on low power that you want to be looking for. These subtle areas of loss of nuclei, you go in and you see if you see true ghost cells. All right, so true tumor necrosis, high grade. Mitotic activity, 3, 4, 5, there are different cutoffs for different tumors. We'll talk about that, but 3, 4, 5 or more per, 10 high-powered fields or 2 millimeters squared, whatever your cutoffs are that you're using. So just always, in this case, didn't really see it, but always look out for those, okay? Okay. Maybe there's one mitotic figure, right? So once you see one, then you go around in the vicinity and you say, can I see 3 or 4 more? Okay. The reason being that those categories are increasingly worse, right? Capsular invasion only, clinically not so bad. Angio invasion, they may treat with radioiodine. Widely invasive, same. High grade, same, plus maybe more, maybe radiation therapy, maybe chemotherapy, maybe targeted therapy, depending, okay? So then the second lesion, on low power. Papillary type of pattern or follicular type of pattern?
Follicular.
More follicular type of pattern, right? We want to, this is the low power kind of thing. What's going on here? Calcs. Are they Samoma bodies? No, right? They're too thick. They're too coarse. So you may have heard, if you've ever read the radiology reports, does anybody know what type of calcification this is called in the radiology reports?
Eggshell.
Eggshell, right? Because it's this, literally it's the shell, right, of the nodule. So you may read eggshell calcs. This usually means there's a thick capsule and the capsule is dystrophically calcified. And the thicker the capsule, to be honest, some people say the more you should be worried about FTC. Okay, so the thinner the capsule or the absenter the capsule, usually these things are benign. The thicker the capsule, think about, this is not 100%, this is just kind of a rule of thumb. All right, so we have coarse eggshell calcs. We have a follicular pattern neoplasm. Now, what do you see about the morphology of the cells? One word.
Salt.
Okay. Some salt and 3 words, some salt and pepper chromatin.
High grade.
Why?
More big.
You can. Can't really call high-grade thyroid cancer on one field. You remember with endocrine organs, you can have random endocrine atypia, right? Where you can have isolated nuclear enlargement. That does not mean anything necessarily bad. What's the color of the cytoplasm? Very pink. What's the quality of the cytoplasm? Granular. What do the nuclei have? Okay, so these are oncocytes. Okay, so this is an oncocytic follicular pattern neoplasm. So remember that oncocytic thyroid neoplasms are a separate category from follicular neoplasms. However, because they are genetically different. What's the genetics of oncocytic things compared to follicular things?
It's all mitochondrial.
It's mitochondrial DNA mutations. What else? Gains and losses, copy number alterations, right? As opposed to the non-oncocytic follicular pattern neoplasms, which we were dealing with in the slide before. What's the molecular of those? RAS or RAS-like. So HRAS, NRAS, KRAS, BRAF, K601E, PAX8, PPAR gamma, right? These are all follicular pattern mutations. So oncocytic, while the diagnostic criteria are identical, just have different genetic drivers. So they're somewhat separated now. All right. But knowing that the diagnostic criteria are the same, does anybody think this tumor is benign or malignant after having looked at it? Or hopefully if you've previewed it. If not, I'm going to drive around the edge. What?
Not as malignant, except that mostly like on the edge.
Yeah.
They're kind of surrounding nerves in some places too.
Okay, excellent. Right, so now you have somewhat more subtle, right, but still something on the other side of the capsule, right? So maybe this isn't a low power diagnosis. Maybe this is a somewhat higher power diagnosis, right? And so in this case, you always have to look right on both sides of the capsule and say, are these clusters of cells on the outside of the capsule essentially identical, right, to the ones on the inside? And if so, then you can make a diagnosis of malignancy. And in many cases now, right, you have these trickling, streaming cords of cells that are present on the other side of the capsule. So yes, we would agree there's another guy right there. All right, so this is again another slightly more subtle example of which type. So what's your line diagnosis? Oncocytic thyroid carcinoma, minimally invasive, all right? So the first one, follicular thyroid carcinoma, minimally invasive. Oncocytic thyroid carcinoma, minimally invasive. It used to be oncocytic subtype of FTC, but as I said, now it's completely its own thing, but the diagnostic criteria are the same. Okay, we look around, we don't see any mitoses or necrosis, fine. Okay. Background. Anything concerning you about these background nodules? No, right? These are little benign adenomatous nodules hanging out in the background, okay? Comments, questions? Good. Case 3, low power. Follicular pattern or papillary pattern? Follicular pattern, okay, excellent. Follicular pattern with a capsule and a little bit of minimally compressed rim. Now we go around and look at the rim. There's a little blip there. There's something here. We have to ask ourselves, is it the same or different? I'll let you guys think about that. So what might be your thought process in this case? Anybody?
I guess I'm trying to still suss out if that thing on top is just normal thyroid that's been pinched off to the side, because this thing's really expansile.
Yep.
That other area where it's trying to almost mushroom out, I thought this doesn't count yet as capsular invasion.
Right.
It's not enough. It needs to be on the other side.
Okay.
Or like shout more.
Yeah. So what are you gonna do, or what can you do to determine whether or not you think this focus is part of the tumor or not part of the tumor?
Consider cutting deeper to see if it connects.
Right, you can consider cutting deeper to see if it connects with a little sort of mushroomy stalk, which is always recommended. Let's say it doesn't. Then what? Morphology, right? Just simply, does the morphology of this stuff outside look like the morphology of this stuff inside? Not really, right? There's a lot of shaking heads. The nuclei are subtly different. The architecture is subtly more compressed, right? So always evaluate these little satellites with a critical eye, right? And match up the inside to the outside. And in many cases, you'll be able to kind of suggest whether or not they're the same. What's another thing that you could do that we can't do because we don't have this functionality here, but if you did, do RAS, exactly. So the immunostains that are helpful for thyroid are BRAF, V600E stain, right, which will tell you if there's a BRAF mutation, and the RAS stain, which we don't have, which tells you if there's a RAF Q61R mutation. In differentiated thyroid neoplasms, those are the only stains that are helpful, right? So you may see on the outside people doing HBME and galectin and CK19 and all those antiquated, don't even look at them, just throw them in the garbage, all right? The RAS immunostain, right, if you have a tumor that you know is RAS mutated, or even if you don't know, throwing the stain on, and if you have one positive and one negative, right, that can help you say that they're different tumors, right, that one is RAS driven and one is not. I've seen that being used in other institutions very usefully. We don't have it yet. We don't have that stain yet, but that's been used in that manner. Okay, good. What else? Okay, so the other thing you might want to do in this type of tumor, right, is make sure you have the entire periphery submitted, right? Because in some cases, this might have been representatively sampled. If you start seeing blips like this or that are concerning, those are the tumors you want to have the entire periphery in on. So we have another section, I don't think I gave you this, of the same tumor. This was an outside consult. So some of it's missing, fine. But when we scroll around the periphery, you have these little blips, again, like James was saying, maybe they're sort of into, but not completely through the capsule. There's another little eggshelly thing. And now you come around and you have this. So now you're dealing with the same problem. Is this part of the tumor or is this different? This is starting to look a little bit similar, right? So now you have to ask yourself, all right, is this a focus of capsular invasion? You do your deepers, maybe you don't find a stalk. You have to ask yourself, do you see fibrous band on the outside of this? Yes. Do you see fibrous band on the inside of this? Yes. So you see fibrous capsule on either side of it. And this is the controversy in thyroid pathology. Some people would call this capsular invasion with recapsularization on the outside of it. And some people would call this splitting the capsule and not being out. Right? Who votes for what? I have no skin in this game. Does anybody prefer one or the other? And does it matter clinically?
Probably doesn't matter clinically.
Probably doesn't matter clinically because I'm asking the question. No, just kidding. But why might it not matter clinically?
You got it all.
Okay. And you got it all, and it's minimally invasive only, right? So the minute you get angioinvasion or high-grade features, then you're dealing with what treatment paradigm? What do they do with patients with higher cancers? Pardon?
Radiation.
Not external beam radiation, but iodine, radioactive iodine, right? So radioactive iodine administration is based on risk of recurrence in thyroid carcinoma. So any of you who are significantly interested, go pull up the American Thyroid Association 2025 guidelines for treatment of thyroid carcinoma. And there's a beautiful, it's in my PowerPoint too, or presentation, whatever. there's a beautiful chart, right? That's like low risk, intermediate risk, high risk. The higher you go on that chart, the more likely you are to need radioactive iodine to ameliorate or to minimize local recurrence, distant recurrence, any recurrence, right? So it's recurrence risk. If you have minimal invasion only or no invasion at all, you do not need radioactive iodine because your risk of recurrence is that low, right? So not all cancers are treated with RAI, it's a risk profile. So in this case, as long as there's no angio invasion, no high-grade features, and the tumor's not giant, so in thyroid, kind of 4 centimeters is like a scary size. As long as it's under that, the patient can be treated with observation only, okay? So you have to know what the clinical treatment cutoffs are for when they start to worry and when they don't. And if it's below that threshold, then you can hedge if you want to, right? So what are our hedging options for these types of tumors? Who has the WHO? So what are the 3 big categories in the WHO of thyroid tumors? You guys all get access, right, with the department? Okay, good. So
benign, low risk, malignant.
yes, benign, low risk, and malignant for follicular pattern neoplasms. So what are the diagnoses under low risk?
NIPT,
Okay.
Thyroid tumors of uncertain malignant potential.
Yep.
Hyalinizing trabecular tumor.
Yes. So all 3 low risk diagnoses, right, do not have the word adenoma in them and do not have the word carcinoma in them, right? They all have the word tumor or neoplasm in them, like stump, right? NIPT, what's the problem with NIPT? Nuclear features, right? What's the problem with thyroid tumors of uncertain malignant potential, or UMPs? Architectural features, right? So in both cases, there are features that either make us think about PTC, nuclei, there are features that make us think about FTC, capsule, or there are features of both nuclear and architectural irregularity. All of those are in this low-risk neoplasm category. They're all variations of so-called UMP, right? Tumors of uncertain malignant potential. As you know who signed out with me, I don't use UMP, but it's out there. I will say thyroid neoplasm with nuclear irregularity, architectural irregularity, nuclear and architectural irregularity, and say these are the diagnostic options, right? But if it's a follicular pattern or a RAS-like neoplasm, mostly your important features are, right, is there capsular or vascular or extensive invasion? Yeah? Does that all make sense? So in this case, you could UMP it, or you could say follicular neoplasm with peripheral irregularity. I don't think this is true capsular invasion, just observe the patient, right? We do that not infrequently because they will observe, right? The frequency with which they observe might change, but over time, right, if they have many years of nothing happening, they'll probably decrease their frequency of observation. If you were so inclined and you were aggressive about nuclei, you might also be worried about these nuclear features because there's chromatin clearing. But similarly to the prior case, the nuclei are very round, right? There's not a wrinkle, there's not a groove, there's not a pseudo-inclusion. It's just chromatin clearing, right? So one feature is not enough. The other thing I want you to take note about follicular pattern neoplasms, right, which we don't always talk about, but we do in cyto, right, is the cytoplasm. And so the cytoplasm of non-PTCs tends to be not so thick, not so dense, more sort of wispy and like, I don't know, grainy or amphiphilic rather than this thick, dense cytoplasm of PTC, which we'll see, right? So always take into account the nuclei, how robust are the features, always take into account the cytoplasm, and always take into account the low sort of power picture of this thing. Comments, questions? And let's say the patient did have something worse. and they only took out a lobe, and they want to give radioactive iodine, what happens? Can you give it radioactive iodine post-lobectomy? No. Why? It will be ineffective because your other lobe is going to take up all the iodine, and it may not be as effective on circulating microscopic tumor cells or residual things in the tumor bed. So the only reason patients undergo completion thyroidectomy is if they're going to get radioactive iodine, right? Completion thyroidectomy is not because there's a positive margin, is not because there's cancer. It's because there's cancer with a high enough risk of recurrence that they want to give radioactive iodine, but it's not so high grade or it's not so aggressive that they're going to give like mondo chemotherapy or external beam radiation, right? It's these well-differentiated cancers with a risk for recurrence that will respond to radioactive iodine, so they have to remove the other lobe to make sure that it doesn't soak up all the therapy, okay? That is the only reason for completion. The only reason is radioactive iodine. For things like anaplastic or bad high grade, they may give BRAF inhibitors or they may give chemotherapy. In that case, completion thyroidectomy doesn't matter, okay? All right, next case, benign or malignant. Malignant, right? Like you can look at this on 1X on the slide and be like, that's really purple. That's no good, right? Really, really purple for thyroid, no good. Multiple satellite nodules of invasion, lots of internal fibrous bands, not just one capsule, right? But like intersecting, small satellite nodules, malignant, right? Excellent. Many diagnoses of thyroid carcinoma are low power malignant, which is why I think the virtual slides are really helpful, okay? So multiple satellite nodules. Now, what type of malignant? Who wants to say what they think or describe? What's the architectural growth pattern?
Papillary, but then it could be some sort of with a certain type of features. If I mean, there's some sort of columnar or tall cell look to it in areas where it's yeah.
Okay.
So I might say with certain features in some spots.
Sure. So we've got a variety of features. I heard there's some papillary growth. Yes. There's some follicular growth. Yes. There's some cells that are maybe more tall, or quote unquote columnar compared to others, right? What about the nuclei?
They look more follicular.
Yeah, they're super round, super dark, speckledy chromatin, not elongated, not grooved, not wrinkled, right? So this is a very nice example, right, of something that may have papillary architecture and may have tall or columnar appearing cells, right, with these very long, strands, but the nuclei don't match, right? The nuclei are very round, maybe focally elongated, but still very plump, right? Not the conventional type of nuclear changes we might want to see for something that's other than just follicular, right? So in this case, it's a very good example of just a bland follicular pattern, nuclei, right, on the background of very complicated architecture. And this is important to remember because the architectural features of thyroid carcinoma are not parallel, right? It's not like follicular pattern neoplasm, only follicles, no papillae, right? It's not like papillary carcinoma, only papillae, no follicles, right? Any growth pattern can be seen in any of those, from papillary to follicular to solid, right? This is, I think, a good example of that. So we have to take all things into consideration: the nuclei, the growth pattern, the genetics, the overall morphology, right? This has the sort of lobulated, broad-based pattern of invasion of a follicular pattern neoplasm. It does not have the nuclei of PTC. So how would you call this tumor?
Maybe widely invasive or at least angio.
Right, so then you're starting to think about maybe this is more than just minimally invasive. So maybe you're thinking about angio invasion because of things like this. Yeah, I don't know if you guys saw this, but there's a thin walled vessel, right, with some fragmented tumor cells in the lumen. Now the question you have to ask here is this true angioinvasion or fragmentation of tumor, right, that floated off into a vessel? What features might argue that this could just be fragmentation?
It's mixed with blood, it's like attached to the wall.
Right, it's and mixed with blood. It doesn't have an endothelial lining. It doesn't have an adherence to the vessel. It doesn't have a fibrin thrombus in it, right? So this could be just fragmented tumor cells that happened when it was sort of cut and like extruded into a vessel, right? So things to be a little bit cautious of. However, you know, you start to see more of these. Could this be lymphatic invasion? This is a tough call. However, this patient had these features, basically bilateral lobes of the thyroid, right? So now we're getting to the like, this is not minimally invasive anymore. Whether or not there's angioinvasion, I don't know, but this is diffusely present throughout the bilateral lobes. Now we're starting to think maybe this is more on what would be the spirit, right, of a widely invasive type of thing. Okay, so regardless of whether you see angioinvasion or not, may not matter if you're calling it widely invasive, right? Because it had the same treatment paradigm. Does that all make sense? This had some weird mutation. It didn't have a traditional mutation. I think we ended up calling it high grade because in areas we saw mitoses and or necrosis. And I'm trying to remember if I put the slide on here where we have the necrosis. Did anybody see it? It may not be on the slide. All right, it's okay. We'll find you some necrosis eventually somewhere. Okay.
So is this find out as a like the high grade follicular derived thyroid tumor then? Whatever
Yeah.
the name of the WHO is for the high grade.
Yeah, so the high grade global category is high grade follicular cell derived, so not medullary, right? Non-anaplastic thyroid carcinoma. So follicular, non-medullary, non-anaplastic. But it's basically like, is it a PTC high grade? Is it an FTC high grade? Or is it an OTC high grade? So I will use those three terms. I won't just say high grade follicular cell derived non-anaplastic because it like, if it's PTC, it's going to be different than an FTC or an OTC, right? So I will just say FTC high grade. So that's what we would have done in this case. Okay. All right, next. Overtly benign or overtly malignant? Or don't know yet. Based on?
So solid. Place. I see the guy left like normal architecture centrally. But I suppose it doesn't really look exactly like a follicular or papillary pattern right now.
Yeah.
So I'm not seeing like maybe normal structures that are just like adenomatous.
Okay.
But I mean, it could be maybe benign. It looks like it's well encapsulated, which is like big pushing borders.
Yeah. So that's what you want to notice on low power, right? You want to notice the borders. So in the absence of overt low power invasion, yes, we always have to go on high power and see if there can be anything. However, in the absence of invasion, you are limited in the kinds of cancer diagnoses you can make. Okay, so very well circumscribed with a little bit of a pokey carrot out here, but I don't know that that's really true invasion, right? That just could be architectural irregularity. So nothing at this point that's a little, I think, inflammatory focus, not tumor. All right, so one, not really a capsule, or if so, a very thin capsule. Two, nothing overtly invasive as we walk around the periphery. However, your point about it being not really papillary, not really follicular, but more solid, right, or trabecular is well taken, right? So this pattern alone is not malignant. Right? This pattern alone is just a pattern. So this, when we say trabecular, this is what we mean, right? There are these long cords of cells that are bounded by stroma that, when you think about, almost look like HCC, right? Hepatocellular carcinoma, where the cords like widen, and you don't have colloid, you don't have other structures. Occasionally, where you get a follicle with colloid, cool. But a lot of this growth pattern is trabecular. The other kind of interesting thing about this is that the nuclei kind of are becoming a little bit ovoid, right, or a little bit spindly. Does this mean anything to you?
The nuclear shape closer to that of a PTC.
Okay, so it's a little bit elongated and a little bit cleared.
Maybe there's some grooves here and there.
Okay. Are you significantly worried about PCC?
No.
No. Right, because the features are still not robust, right? If you were worried about any tumor, what might it be? The word trabecular from the thing.
Hyalinizing trabecular tumor.
Right, you could think about hyalinizing trabecular tumor because of the trabeculae and the circumscription, right? So those are common features. However, what about this tumor does not match hyalinizing trabecular? What does it lack? It doesn't have too much stromal fibrous hyaline bands. Some of them don't, but the stroma here is very vascular, right, and finely collagenous. It doesn't have the thick bands. What else is missing from a hyalinizing trabecular tumor? And now we're talking about the nuclei.
It's more like grooves and
Yes, so hyalinizing trabecular tumor has, in any other circumstance, nuclei that are like 5,000% papillary. They have beautiful pseudo-inclusions, tons of grooves and wrinkles, thick, dense cytoplasm, right? They just happen to be arranged in trabeculae and happen to not be invasive and happen to really not ever metastasize, right? Otherwise, the nuclei are PTC, okay? The nuclei have inclusions. This doesn't, right? Zero inclusions, barely any grooves, just slight elongation and slight chromatin clearing. So these are the kind of features, right, that really should not worry you for any kind of malignancy, right? It's circumscribed, yes, it's trabecular, yes, the nuclei are a little bit unusual, right? But one of the things to always look for in the background, right, is, do the background nuclei also look unusual? Because in some cases, right, it could be processing artifact. And if your nuclei in the background are equally as cleared as your nuclei in the tumor, then, you know, you can't really use that as an indicator. Does that make sense? So we haven't really done that yet, but we could go back, right, and say, all right, in this, oh, this was the oncocytic one, so probably not going to help us. This one had some nuclear clearing, not much going on in the background, but kind of different, right? So in this case, not helpful. That was kind of one. So just food for thought, right? Just food for thought in terms of comparison to the background. In all of these cases, the background was different from the tumor, so fine. Okay. Questions? Next case.
What is the final diagnosis?
Oh, final diagnosis for this one is basically an adenoma or an adenomatous nodule with trabecular growth. Yeah, thank you.
Also, we would do the PTC stain.
You could do a BRAF. It'll be negative. If you have molecular knowledge from FNA, that could be helpful as well. Let me see if this one had a mutation. No, it was not done. Mutation was not done. So BRAF negative, no mutations. But yeah, you certainly could do the BRAF and it should be negative. Okay. All right, next. low power growth pattern. Follicular. Capsule with coarse capsular calx. So kind of eggshelly. In this case, this is another outside consult. They did a nice thing, right, where they did multiple strips of capsule on the same slide so we can evaluate it. I don't know why some of it is a little bit like foldy and wonky. Maybe they cut it fresh, I don't know. This is why we don't cut our thyroids fresh, right? Because we don't like this slippage and folding of tissue planes. We like good intact sections. These are a little bit slippy and a little bit foldy. Okay. So we have a capsule with calx, and we now have tumor morphology. Small, thin papillae, mostly follicles. Excuse me. Now what do you think about the nuclei? And I'll keep going around the different areas because the preservation here is not always great.
A little bit more cleared out
Mm-hmm.
than I think we've seen in the previous follicular
Yep.
neoplasms.
Yep.
Have background thyroid to see if, because if they roast this fresh, then I guess I'm curious if there's any other thyroid here that, okay, yeah, it looks like a real difference.
So grooves, funny like half moon or like semi-lunar shapes, right? A lot of these demi-lunes. A lot of overlapping and grooves. Right, so now we're starting to build, we're building more, right? We're building more features than just chromatin clearing on the background of round nuclei. Now we have chromatin clearing plus. Chromatin clearing, cup shapes, grooves. What do you want? What do you want to know? What do you want to do?
Was this FN8 before?
It was.
Do we have molecular results on that?
We do.
What did it show?
BRAF, V600E. Okay? So these are rare, right? These are very, very rare. But the completely follicular patterned BRAF V600E PTCs do exist. And you have to be very, very careful, right, about looking at all of these nuclear features. And the minute, even if on the other cases, right, you were worried, throw on the BRAF IHC. It's not going to hurt anybody, right? In this case, definitely throw on the BRAF IHC if you don't have any other knowledge. This was sent to us in consultation, like for help with the diagnosis. It already had a known BRAF V600E from the FNA. It is PTC. You cannot have BRAF V600E and not be PTC. You can have BRAF V600E in a completely follicular pattern, circumscribed and basically encapsulated tumor. Okay, these are rare, but they exist.
Would there be rough state well on these freshly grows?
Yeah, it works okay. Works okay. You may get better fixation at the edge, right? So if it's negative or weak in the unfixed portions, always be mindful of that. But if you have good staining in the fixed like edges, then you should be fine.
So how does not have that BRAF mutation, PTC-like features that are really worrisome, it's really encapsulated, that's when you think this, like
If the BRAF mutation is absent.
yeah.
Yeah.
Okay, that was
Yes.
and you would think that.
Yes. All right.
Space.
Yeah.
Remember, did they think it was completely encapsulated, or like, do they think there's areas where it like was invasive? It's kind of hard to tell with
It's very hard to tell because it's like folded over. There was no like overt big invasion. There was maybe like little trickly looking stuff happening, but nothing like big. So the way that PTC invades through these capsules is often not in that broad-based manner like follicular, but it's often just like a subtle or like subtly little guys. Little guys start to trickle out and then trickle all the way out. That would be the pattern of invasion in the BRAF types of tumors, right? So it starts kind of like this, right? Trickle, 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 and then it just keeps trickling out. The other one, you might not even see that there's a nodule, right? But there is. It's very colloid rich. It doesn't really have a good capsule. But it's got the same nuclear problem, right? It's extremely cleared and grooved and cup-shaped, and also small abortive papillae, right? Small, but well-formed papillae, right? With thin fibrovascular cores, kind of complex, okay? This is another example of the same thing. This is BRAF V600E, right? So be mindful of the robustness of the nuclear features, the presence, even if focally, of small abortive papillae, and do the BRAF. This is PTC. I'll point out the difference, right, between some tumors that maybe have, I don't know, like larger, more broad papillary-like structures that are probably less, like this one, right? This one also had some evidence of these kind of broad papillary structures, but the nuclei weren't there, right? So it's always a combination or a conglomerate of features. So these are two examples of BRAF V600E positive PTCs, right? So always, if your differential is NIFT-P, but it's too much, right? It's possibly BRAF. To compare, I don't think anyone is going to have a problem with this diagnosis. Right, extremely classic PTC, complex branching papillae, little trickling kind of invasion out into the normal parenchyma, elongated papillae and follicles, really wrinkled, cleared, grooved, all the things, and if you'll notice, abundant, thick, dense cytoplasm. The PTCs in the two prior cases that were the follicular pattern ones didn't really have that same cytoplasm, right? So it's not always there. But if it is there, like in this case, it can certainly be helpful. All right, so now we have a PTC, but you can't just stop there. What do you see at the edge? Muscle. So whenever there is a significant band of skeletal muscle at the edge of thyroid, something is wrong. Clinically, they do not take muscle, right? They shell the gland out. There's a tissue plane, right? There's a plane in front behind the strap muscles, and there's a plane in back in front of the trachea. They get in that plane and they take the gland out. The minute they start taking skeletal muscle, you know something in the OR was not right. So don't ignore it. when you go look in the muscle.
Yeah.
Yeah, right? There's PTC in the muscle. So what does that mean for the patient? What does this change for them? Pardon?
Maybe like a dissection for these.
For like nodes?
Yeah.
Mm-mm.
Maybe the completion.
They probably need a completion with RAI because now you've given them what? You've given them a different T stage, right? So we'll talk about what this all means for therapy. But yes, when there is gross, macroscopic, or microscopic with clinically confirmed, right, extra-thyroidal extension into skeletal muscle, this is a higher T stage. I somehow missed, I think I had a BRAF IHC on this one. I apologize it didn't make it to this presentation. I can throw it in there later. But these are BRAF positive, right? So if you ever need help knowing whether these crinkly things in the skeletal muscle are tumor or like, you know, vessels, for example, do the BRAF. And this was BRAF, this will help you. If it's BRAF positive, right? Or you can do something like Paxate TTF1, right? But so yes, so now you like, okay, when they take this much skeletal muscle, something clinically is wrong. You see microscopic PTC in the skeletal muscle, you can pretty much assume that it's clinical or macroscopic ETE because they thought something was wrong, you confirmed something was wrong, so now you upstage the patient. So now they get, if they don't already have it, completion with RAI. Normally, if they're taking this much skeletal muscle, probably they're already concerned for something aggressive, so they'll probably have taken the other lobe. Probably, but not always. Back to your question of neck dissection. When do patients with PTC get neck dissection? If there's clinically or radiographic evidence of metastasis preoperatively, right? So they do physical exam and they do ultrasound mapping. So for all thyroid cancer patients or thyroid tumor nodule patients, you will see preoperative thyroid ultrasound and neck mapping. It's a study in the imaging. They look at the gland and they look at, levels 1 through 5. If there's nothing radiographically in levels 1 through 5, they won't get a neck. So unlike SCC, right, where, depth of invasion of tongue will buy you a lymph node dissection. For thyroid, it has to be clinically or radiographically evident for them to get a neck. They don't worry about micromets, okay? If in the OR they palpate nodes, they might take them out even if they were radiographically unsuspicious, right? But that's when they get nodes. In this case, the nodes are irrelevant to this, but the possible treatment with RAI is relevant, right? Because now you've upstaged it. Okay.
So if you have skeletal muscle stick to the class, you probably, if you don't see it up front, you will cut deeper to chase.
No, I won't chase it if I don't see it. Because there are a few things that could happen. I make sure I submit all the muscle, but I won't do deepers. One is you could have overt invasion. 2 is you could have a lot of desmoplasia at the edge of tumor that just sticks the muscle to the gland, but doesn't actually invade. So that's been some circumstances, right, where we've said there's desmoplastic adherence of tumor to muscle, but I don't see overt invasion of muscle, therefore I can't upstage it. But normally, if it's in the muscle and they took it, I would just upstage it. If it's in the fat only, that doesn't upstage it. The other thing to be cautious about with thyroid, which we've now started doing, which you guys are doing well in the gross room, right, is inking the posterior surface a different color. Because there's no room against the trachea, right? There's room for the skeletal muscle. They can get a wider margin in front. But if the tumor is posteriorly located, they can't get a wide margin in back. And so if there's a positive margin on the trachea on the posterior side, that's also a poor prognostic indicator, so they'll probably get RAI. So they want to know the anterior versus posterior margin status, which is why we started inking differentially. Okay? Okay. Next. This is a tougher one. Benign or malignant or not sure. Not sure. There's lots of nodules. Are they all the same? Or are they all different? They all seem kind of separated. So this came as a dominant nodule, which is now marked by the black. This is a dominant nodule that was FNA and molecular was done. And there was a finding in the molecular that kind of recapitulates what we see on H&E. There are these multiple nodules, right? Some are very small, right, in the background of normal parenchyma. This is a second slide from same patient. But they don't really like connect to each other. Right? So you want to ask yourself, are these all satellite nodules of invasive carcinoma, or are these all separate nodules? What might be an indication, or what might you think about with this morphologic pattern of multiple small nodules, all geographically distinct, that you aren't necessarily convinced belong to each other? What's
Have a thyroidectomy before.
No, this patient did not have a thyroidectomy before. So if they did, and you saw this, then you might think about recurrent cancer, right? Or just recurrent growth of multiple nodules. But they did not have a thyroidectomy before. This is their original surgery, and there is definitely some normal thyroid in the background. So no, it could be regrowth of follicular nodular disease, or it could be regrowth of carcinoma, but this is their primary surgery, so it's neither of those two things. Some of these nodules have lipomatous stromal metaplasia. Does anybody know what I'm getting at here?
Some like genetic syndrome underlying this.
There's some genetic syndrome underlying this.
FAP or A.
What's the tumor that's associated with FAP? Desmoid, but what's the thyroid tumor that's associated with FAP? It's cribriform morular. Is this cribriform morular? Did I hear somebody say what the syndrome is? P10, Cowden. Thank you. So this is P10. This is P10 syndrome. P10 hamartoma. So multiple back-to-back bland appearing adenomatous nodules with sort of intervening normal, varying sizes from teeny weeny weeny to big. Think about P10. The other thing that the P10 tumors sometimes have is they have lipomatous stromal change. Sometimes they have what's been described as like a nodule in nodule appearance, where there's like areas of hypercellularity within a larger lower cellularity nodule. On the FNA molecular, there was a P10 mutation in the FNA nodule. There was also a RAS mutation, but this could be a RAS mutation developing on top of, right, germline P10. There is P10 IHC, which we don't have, but Mayo has, that will show loss of nuclear expression, right, in the nodules. So always, this is rare, right, but you can make the diagnosis if the patient doesn't already have a known diagnosis. In this case, the patient didn't have a known diagnosis. Fortunately, it was found on the FNA molecular, but even if it weren't found on the FNA molecular, this morphologic pattern should trigger you to do the P10 stain and or ask the clinician to work up the patient for possible germline. These patients can get thyroid cancers, they can get, I can't remember the whole conglomerate of tumors they get, but, oh, it's 901. All right. I put at the end, I don't think I gave this to you, But at the very, very end of this presentation, which I'll send out, is this tumor, which is what you asked for. So I'm just gonna give you the answer so you can look at it on your own. This is a follicular and sort of papillary pattern neoplasm that has elongated dark nuclei, but again, not really PTC nuclei, not cleared, not wrinkled, but elongated and maybe grooved, but with very fine chromatin. It has these punched out holes, so maybe quote unquote cribiform, right? This is cribiform morular. So these are no longer considered a subtype of PTC. They are positive for TTF1. They are negative or very weak for PAX8. And they are very strongly positive in nuclei and cytoplasm for what? Beta-catenin, right? Since these are FAP Wnt pathway associated. The normal beta-catenin, right, is membranous only. Right, so at the very end of this presentation, this is the second syndrome, right? This is cribiform morular carcinoma. Don't always say, oh yeah, there's papillae, there's some solid growth, cool, it's PTC, next case. No, these are not the nuclei of PTC. This growth pattern with these punched out cribiform spaces, right? And almost columnar, you guys mentioned columnar before, almost columnar-like morphology. There is a overlap between columnar carcinoma and cribiform morular. So when you see this kind of pattern, which we also saw in that high-grade case, right, that had some other mutation that was neither PTC nor FTC nor cribiform morular, it was something else. But when you see this columnar type of pattern, think about cribiform morular, think about columnar cell. Cribiform morular is easy. PAX8 and beta-catenin, done. Okay. In the last 2 minutes, the remaining tumors that I gave you, I think it was this one, this one, this one, and this one. I want you to go and look at these. All of them are NTRK fusion tumors. Okay? They can be extremely varied in morphology. The classic NTRK fusion tumors are widely invasive. They often have a predominance of follicular patterned growth. And the nuclei are not overwhelmingly papillary. They're subtly shifted, subtle nuclear clearing, but usually no good psammoma bodies, or well, no good pseudo-inclusions rather. They do have psammoma bodies, right? So they have this hybrid morphology between follicular patterned growth, minimally atypical nuclei, but usually widely invasive, and they may have psammoma bodies. The other types of, this is another NTRK fusion tumor. This is very well circumscribed. It has only subtle, right, invasion at the edge. And you look at the nuclei, you're like, wow, those are not bad at all. But on FNA, right, this was an NTRK fusion. Basically, by definition, similar to BRAF, these are effectively malignant. One up here, you're gonna say, Nicole, where's the tumor? Follow the psammoma bodies, okay? In this case, the tumor is extremely subtle, and it blends with the background normal, right? So tumor, normal, right? This is really effing hard. If you have the IHC, you'll be able to pick these out, but you may see a subtle shift between this and this. This is tumor, right? This is benign. And these are the lymph nodes, right? So this is real, right? This is the NTRK tumor in the lymph nodes. So I want you to be aware of how subtle the NTRK tumors can be. This is another example of one that's widely infiltrative, but maintains the follicular pattern and only has very, very subtle if absent nuclear features of PTC, right? So you look at these and you come up with your own conclusions. But I am of the opinion that the NTRK tumors are also not PTC. There's something else. They're fusion tumors, right? You cannot tell me that this follows what we normally think about of the nuclear pattern of PTC, right? It just doesn't. It's a thyroid carcinoma, yes, right? But the fusion ones are different. There's the RAS things, there's the BRAF things, and there's the fusion things. The fusion things are generally, the NTRK ones are sort of, if you look at my presentation, right, they're sort of slightly BRAF-like to slightly RAS-like, according to the like molecular profile, right? So they're not overtly BRAF-like and they're not overtly RAS-like. They're kind of somewhere else and somewhere in the middle, okay? But I wanted you, these don't come very often, but the more we're doing molecular testing, the more we are seeing them, and I want you to be able to recognize them. In this case, this is the same patient as this one, but it has this giant thing outside here, and I just wanted you to recognize, right, that this is a vein, right? This is venous vascular invasion. I think we've got some different immunostains. Of course, now my hour is up, so it's killing my slides. But I'll send you guys out this link. You can look at it on your own. Is that helpful?
Very helpful. What was case 5? It was the one that looked like it, maybe an HTT, but it's not.
Oh, this was adenomatous nodule with trabecular growth.
For the follicular associated with like a germline or something like the P10 pattern, if you discover either I guess on FNA or like follicular or something on the resection, how would you sign it out? Would you probably sign it out before the molecular is back?
I would say multiple adenomatous nodules in the context of P10 or C comment, because you can't make a syndromic diagnosis. You can only say that there's P10 mutation or P10 loss on this tissue. Please work up the patient for germline, right? So you can say, with suspicion for P10 hamartoma syndrome if you want, but I would probably just say, multiple adenomatous nodules, but I wouldn't call it follicular nodular disease, right? I would say, see comment. This is not like benign follicular nodular disease. This is likely to be P10 hamartoma syndrome. Check patient.
With the NTRK ones, if you don't have fusion studies before,
Do it.
well, yes, but I guess how would you sign it out? Would you wait for fusion studies if you had a suspicion for NTRK?
No, I would probably just, these technically are still under papillary. So you could, in all good conscience, call it PTC and just say, this is BRAF negative. I suspect a fusion, do the fusion. That's what we've kind of been doing. Because for now, they're still PTCs.
For these, like TB6 and these like
Yeah.
NTRK fusion
Yeah.
thyrocarcinomas, is there anything you need to report beyond kind of what you do normally
No.
to help your clinicians?
Everything is the same. LVI, HDE, high grade features. But if you think it's fusion, the knowledge that it's a fusion may help in the future with treatment. They probably aren't going to give NTRK inhibitors right away. They'll still try RAI, but knowledge may help in the future if it comes back or becomes more aggressive. So I would pursue the fusion testing. So it's no. Other than that, no.
Of the NTRK one that doesn't look like PTC,
Yes.
would they something to trigger using it? It could be a fusion rather than just like a adequate thing.
Yeah,
Because if you
yeah.
don't have the fusion, then it gets
Yeah.
tricky.
Yeah, so more often than not, they are overtly infiltrative. This one was a very weird example of only very subtle infiltration, right? But more often than not, they are overtly infiltrative. More often than not, they have an overwhelmingly follicular growth pattern with only subtle papillae. And more often than not, the nuclear features are, like I said, kind of not very robust. And if my BRAF IHC is negative, confusion. Okay, what else? All right, thanks.